Hi, my name is Dr. Hastan Haidershah. I'm a consultant neurointerventional and interventional radiologist working in Dubai, trained from the US and Canada. I've been asked to discuss COVID-19 and some of the radiological manifestations of the disease. And as you may know, that sometimes the radiology is actually more accurate than the blood tests. Many times the patient will be asymptomatic, and when we do the x-rays or we do a CT scan, we will actually find image findings that are consistent with COVID-19, even though the blood test, either the serology, the PCR, or the IgM or IgG has not become positive yet. So especially CT scan is probably the most accurate test right now for patients who are symptomatic with COVID in the respiratory system. So of course, prevention protocols are very important. When patients are coming to the x-ray facility, they should be properly protected, and staff should also be properly protected with standard procedures. And also the CT scan and x-ray machines should also be cleaned before and after the patient's arrival. So of course, you work with your local clinicians when you have a high suspicion, and there's also some blood signs, for example, raised white count or lymphopenia, then you also can be more inclined towards a COVID-19 positive patient. Also, CRP usually is positive, so also another sign of inflammation. So these are the three common signs: white cell count, lymphopenia, and CRP. The other things you should look for: respiratory history and smoking history is possible. So chest x-rays can look sometimes very vivid. As you can see, this patient has severe disease and severe changes with both what we call ground glass changes and atelectatic changes and parenchymal changes in the lungs. But CT scan is probably more accurate. Here is a typical kind of patient who comes in, a young patient you can see with COVID-19. Now, looking at this chest x-ray, you may not see anything really going on. This is something external to the patient. And here is actually where the finding is. And here you can see just a very, very faint shadowing and grayness or increased opacity in the lungs, but still you can see the lung parenchymal tissue through this. And the CT scan is really more accurate. You can see this typical ground glass appearance. And this ground glass refers to glass when it's really cut down and very fine. This is the kind of appearance typically seen on CT scans. Now there are certain appearances, and we're going to talk about these certain patterns. So with CTs, we talk about CT patterns. In this case, classic COVID-19 has this what we call ground glass appearance, crazy paving, peripheral location, air bronchograms, and sometimes a reverse halo or a perilobular pattern. Probable cases, so this is 100% confident. If you have these findings, you can be sure that patient most likely has COVID-19. Now, when we go to probable cases, when you have a lower lobe predominant bronchocentric consolidation, some scarce GGO, or again the halo pattern or perihalo pattern, which is reversed, that's again fairly confident, 71 to 91% that patient will have COVID. Then some indeterminate cases, so this is 70% or less, when they have patterns on CT that are not fitting the classic patterns of either ground glass, crazy paving, or the halo sign. Where you can have other signs, lobar pneumonia, cavitating infections, lymphadenopathy, and fibrosis. And understand, with COVID, you can get secondary infections. So sometimes if the patient is presenting late or their respiratory symptoms are very severe, you may get that non-COVID looking pattern where you have a pneumonia or you have a cavitating infection. It's still positive, but it's now a secondary infection in addition to COVID. So we're going to go over a few examples here and just to show. So this is the classic pattern on CT for COVID. And this is what we call ground glass. So this is the ground glass appearance here, and this is crazy paving. See this? Where you have thickened areas and some light areas, and you have some thickened areas in between interspersed. So you have what's called interlobular and interlobular septal thickening. And this is the typical crazy paving pattern that you can see with some areas of consolidation. So here the lung is becoming consolidated, which means that the alveoli are now filling with inflammatory matter. And usually inflammatory white cells are the most common, and usually often lymphocytes, because again it's a viral infection. That's why you have lymphopenia. So you'll have this consolidation going on over here. Now if we go through here, here's another classic ground glass pattern. And here's a reversed halo we were talking about, where you have a center nidus of infection and then you have a clear halo around it, which means that the body is trying to fight that infection. The body has now surrounded that infection like an abscess, and it's actually trying to clean the lungs as much as it can. So this is a typical reversed halo and the perilobular, and you can see kind of lower lobe and peripheral, very peripheral pattern. Now, this is the organizing pneumonia pattern, where you start to get these consolidations, and you can see all these multiple reverse halos. So you have multiple centers of infection in the lung here, and again, typical reverse halo pattern. This is the fuzzy arcades pattern we talk about, where it's perilobular. It's kind of focal, linear, and consolidated patterns, which are not very highly focalized yet, and just more in a linear pattern. Now, this is a kind of probable COVID pattern. You can see again, you have ground glass, you have some initial ground glass here, again periphery, and some of that fuzzy arcade over here. Now, this is a more indeterminate pattern here. With this kind of pattern, you can't tell for sure. There is a little bit of ground glass, but it's a very, very faint ground glass. Here you have some tree and bud or some microvascular pattern going on. This is not very clear. Is this COVID or not? You would have to kind of correlate with the patient's clinical features, especially the blood tests and also their respiratory symptoms. This is a typical non-COVID pattern. So this is typical. You can see kind of tiny little focal millet seed or miliary seed pattern. This is uncommon in COVID, and this is more tree and bud, we call these, where if you look at microvascular level, there's very tiny little trees and little buds that are arising off, and you get this peribronchial pattern. This is more common with a lymphoma or certain types of infections. So the patient may be still COVID positive, but they have a secondary infection now along with. Now, another important thing is that these chest CTs will undergo changes over time. So these patients will sometimes present with a typical pattern where they have just minimal ground glass, but over time that ground glass can become consolidated. You can get halos, you can get some areas of even possible necrosis here, and you're getting more atelectasis and consolidation of lung tissue here, and you're losing a lot of lung volume. And this is how patients get worse. And you can see this is from January 27th to January 28th to February 7th to February 13th. So within, basically, within a 2-week pattern, this ground glass becomes consolidated, and that's very important to know. So sometimes you may only see a certain picture in time. You have to think about doing multiple CTs for some of these patients. Again, the chest x-ray, bilateral, peripheral, perihilar, and more peripheral, sorry, not perihilar, but more peripheral airspace disease and ground glass pattern. This is a poor quality film. You cannot really make a judgment from this kind of film. You need better films for this. Again, classic peripheral ground glass, crazy paving, and organizing pneumonia. That's the classic pattern on CT. Then we have the indeterminate pattern where you have a little bit of ground glass, some patchy changes, fibrosis, and you see the fibrotic changes and more complex pattern. So this is either COVID with another secondary infection or a more severe form of COVID. And then you have non-COVID patterns where you have concavitating infections or tree and bud changes or something with effusions. These are probably not COVID, or they may be COVID with something else underlying, or the patient has an underlying respiratory disease and they also have COVID at the same time. And of course, your normal lung pattern, you should also be able to see, look for normal lungs, also looking for that pattern. So again, looking at some of the parenchymal changes, we talked about sizing, and the more severe, usually over 3 centimeters, if you start to notice either ground glass or consolidation, that patients are usually more severe. And of course, pure ground glass opacities, and some of these, again, if they're 3 centimeters or less or greater, that will usually indicate severity or not. So size is very important. So some scenarios to consider: sometimes you'll have incidental, unexpected findings on chest x-ray. You still probably need to do a CT. CT is still probably the most accurate. Now, understand, sometimes patients present, recently we had a patient who presented with abdominal pain, and we checked them, and the lungs actually also showed ground glass pattern, but the patient actually presented with mesenteric ischemia. Now notice, understand, COVID also has a thrombotic picture, and we know that there's sometimes thrombosis in the arteries or the lungs, and sometimes those thrombotics can present as abdominal pain. So a patient had mesenteric thrombosis and presented with severe abdominal pain. So remember, when you're getting a CT scan of the abdomen or pelvis for abdominal pain and you think there's a possibility the patient could be COVID, I would probably do a chest CT at the same time. And that's pretty much it. So that's the radiological patterns, preferably mostly on chest CT, and what to look for if you think a patient is COVID positive. Thank you very much. Dr. Hassan Haidershaw signing off. Thank you.